I thank Dr. Viraj for giving me this opportunity, and I thank Dr. Priyanka for setting up a good program, scientific program for breast cancer. I was seeing outside, there's a nice ice cream served, and I was thinking, okay, whoever had ice cream, how are they going to stay awake post lunch? So let's see, but it is okay if somebody wants to sleep. So we have that. So the topic which was given to me was recurrent breast cancer salvage strategies. So let me start with Dr. Prajapati. Dr. Prajapati, what do you think by this topic? Does it mean that in recurrent breast cancer we have to supposed to talk only about cure or control also? What do you mean by salvage strategies?
Sir, so I don't know whether that metastatic recurrent or only local recurrent. So, what is the intent? I cannot tell in this whatever they mentioned.
You cannot tell this.
Yes.
So you have recurrence of localized recurrence, loco-regional, metastatic, and distant recurrence, right? That is there. Dr. Jigna, this is whenever you type something in Google nowadays, the first thing comes is the AI response. So this is the AI response which I have put here, that if you have a local recurrence, you have a 5-year survival rate of 72% and 10-year of 58%. In your practice, is AI correct or AI is hallucinating?
I think predicting all these things depends on many factors. So I cannot.
Local recurrence overall, the 5-year survival is 72%. Everything put together.
I think this is fair enough.
This is fair enough. Okay. Dr. Tanay?
Yes, sir.
In your practice, you agree with these figures?
So, to a surgeon's fortune and to the patient's misfortune, breast is such an organ that almost 90% of the recurrences are systemic. So we just say कि आप इनसे मिलके आ जाइए, हमारा role नहीं है. But this data seems quite correct. If the patient has got only local recurrence, then there should be the survival data.
Dr. Rajdeep Gupta, if you look at the metastatic or distant recurrence, especially in a distant recurrence, they have said 5-year survival rate varies from 27 to 47%. That means in early breast cancer, we have treated them for whatever we are. After that, they have a distant recurrence. Still, we can tell the patient that there is a 50% chance approximately that you will survive for 5 years. In your practice, you agree with this figure?
Sir, for hormone positive setting, I agree with this setting. And for hormone negative and only HER2 positive or TNBC, this data seems to be somewhat high for me.
Somewhat?
High. This percentage looks like...
High. We have students also, right? Divita, if you open up a Divita textbook of oncology, the first thing they have written is, due to advancement in oncology techniques, irrespective of the type of cancer, stage of cancer, grade of cancer, 5-year survival rate is beyond 50%. Do you agree with that? Yes. Okay, perfect. Perfect. So now, it looks like that AI is not hallucinating, because once I tried making PPT through AI and I felt that they were hardly 60-70% correct. Remaining 30%, I didn't know where they got it from. Okay. Dr. Tanay, since you are a surgeon, let me ask you, if you have a ipsilateral local recurrence, how do you know it is recurrence versus new primary?
So, there was one very vague description about this, that some Chaudhary et al. Criteria were there. So it all depends on after how long the disease has recurred, what is the biology like, the luminal status, whether it was different or it is the same. Then if it is invasive disease previously and now it has got only in situ recurrence. So these are few of the criteria by which we can tell, but there is no clear-cut demarcation or distinction by which one can tell then this is the new primary or a recurrence. I mean, somebody, if she has undergone a breast conservation and tumor is there in the different quadrant, then we can very well say that it's a new primary, but otherwise there is no clear-cut demarcation.
Dr. Ruchit Shah. Rushit or Ruchit?
Rushit.
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 Okay. Dr. Rushit, one line I have written here that almost all patients with BRCA positive have new primary on the ipsilateral side. Is this correct? Is this not correct?
Not absolutely, sir. Yes, BRCA positivity can have new primary on ipsilateral side, but at the same point of time, they can develop contralateral new tumor.
Okay. Dr. Prajapati, what is your take? This BRCA positive.
Yes, sir. So that is not absolute right statement that BRCA positivity is the new primary only. It can have the new primary, but BRCA positivity also there is a recurrence.
Okay. So this is 2000 article which I had put, and what Dr. Tanay was telling, they had included all those criteria and they found this is how you differentiate between the two. But in 2000 article, and then you have a 2016 and 2019, more than 90% of the patients with BRCA positive have new primary on the ipsilateral side. This was a revelation to me also, because we see BRCA positive quite frequently nowadays, and we have to be careful with whether that's a new primary or it's a recurrence. Okay. Dr. Rushit, do you think that AI or ctDNA in future will predict recurrence before it happens?
Yes, sir. It is. I would say it is too early to say, and we need more data on that. But it is quite possible.
Quite possible. Dr. Gupta, you think this is going to be the future? And I'll tell you, this is the Nature article. We all believe the Nature journal is very good. And there's a Nature article where they say that AI machine learning can now predict when and where the recurrence is going to be there. What is your thought, Prabha?
So I totally agree with that. ctDNA can predict the future recurrence, and AI may be helpful for the pattern of the recurrence, as you told.
Okay, perfect. Dr. Jigna, what do you think? Machine learning future?
I think I will wait for the future.
Okay. Dr. Rushit and Dr. Prajapati after that. This is ESMO Open. It's a short communication. They have the way we have in colon, now in breast also. In fact, this ESCO, if you see, lot of circulating tumor DNA based treatment modification, all are in trial phases, but they are there. So this particular, it's a short study, but what they found that from 3rd month till 18th month, if your ctDNA MAF increases, that predicts the recurrence, and almost 80% of the patient relapsed, those who had ctDNA positive. So let me start with Dr. Prajapati. Dr. Prajapati, how does this help, assuming that this is there today? My question of asking that is, can we change the biology of the recurrence by early detection?
Yes, sir. So like we have data that in also lung is coming with that ctDNA in colon also. So in breast, that's a new thing. So if the ctDNA rising, there may be some micrometes we are seeing in the blood also. So I don't know the sensitivity and the specificity that I mentioned here, but it's new coming. So I cannot tell right now that what will that exactly. So we'll wait for that.
Dr. Tanay, you have done axillary lymph node dissection. You have 10 lymph nodes positive. And you say 10 lymph nodes positive, no matter whatever we do, ultimately there's a very high chance patient is going to relapse. Do you think, if any of known to or any family member, would you use this technology ctDNA, and you say that at least early recurrence, I may be able to salvage this patient? Or it's an opening up a Pandora's box?
It is more like opening up of a Pandora's box, but a lot of other factors also need to be taken in consideration. If a patient has got 10 nodes positive,
10 nodes positive, triple negative,
yeah,
key
so
67,
I assume that this patient,
P.
I assume that this patient must have undergone a neoadjuvant therapy and then have undergone
All
the
standard
surgery.
treatment,
Yes. So it all depends on how the patient had responded to initial systemic therapy. So somebody who's not responded completely or even
so
partially
finding
to
10 lymph nodes, that means
yeah.
patient has
So
not responded
in
well.
that patient, in these sort of patients, ctDNA can be of help. That is what I assume. Somebody who has responded very well, probably it is like still a doubtful role, but in this sort of patient, definitely.
Dr. Rushit, do you think that ctDNA in such patients, right now you would go, we don't have a full data, right? Anyway, all of us will have to wait. Colon mein we have a 5-year data, still people are not doing it regularly. But somebody known to you know this patient is going to recur, do you really think that ctDNA would help?
Yes, sir. So this kind of high risk patient, we will obviously offer the best possible treatment required.
We have given everything possible.
Yes.
Patient is on capecitabine right now. Triple negative hai, to capecitabine ही रहेगा वो.
Yes. So after giving all those treatment, still there is a risk of recurrence, and by doing this test, we may be able to prognosticate, or we can be able to know that whether she is at high risk of recurrence or not. But whether we can change the course or we have an active intervention. So until we don't have that, we can just offer the test, like it can just be a prognostic test.
No, if you don't know, yes ma'am, if you don't know what to do with the test, never offer that test. Okay, that is, yes Vani.
You just said it.
No, I would do it. I'll tell you, Vani, that I would do it because I know this patient is going to relapse, and I today don't know whether I'll be able to change the biology. But the entire premise of screening is based on this only, right? So I would offer to my relative or my known to, and in fact in colon I have started offering to almost all. Yes ma'am.
So essentially the previous older trials where we had intensive screening versus not have failed to show any survival benefit. Now whether you go intense, more intense, and to bring it down to ctDNAs or any molecular test that you want to do, you're still going to get the same result. It's not the early detection, because early detection and intervention has not changed outcome so far. Now is a premise that you keep working on.
Absolutely.
Which is how screening worked, which is how everything else worked, and you said it there.
Absolutely. So each to their own. I think the data is not mature, so what Dr. Vani says or what all the panelists say, everything is fair. We all have this thing. So let's come to today's discussion. And so this slide says that you have a local recurrence in a breast cancer patient, just in breast or chest wall recurrence. There is no clinically overt axillary recurrence so far. Okay. Now let's come to Dr. Tanay and then Dr. Jigna. Dr. Tanay, they have written here, if you have done BCS before and no RT, and I want to know from Dr. Jigna ma'am के आज की तारीख में कौन RT नहीं देता BCS में, but first Dr. Tanay, you would repeat BCS. We all give BCS followed by RT. 0.5 centimeter के नीचे का निकलता नहीं है, but we all give RT. So would you do a re-BCS in a local or chest wall recurrence?
I will do re-BCS only with two conditions if the patient is able to meet that. One is for sure that patient has to receive adjuvant RT, and prior to undertaking her, I'll make sure that there is only unifocal recurrence and not multifocal, and I may use MR mammo for that also.
Okay, so here they have written that if the patient has received RT, they would not offer re-BCS. Dr. Tanay, I'm looking at clear-cut NCCN guidelines. BCS, RT, local recurrence, do not give second BCS.
It depends on.
See, we medical oncologists rely on surgeons. हम लोग surgery में detail में नहीं पढ़ते हैं. So I need that answer from you.
We won't disappoint you as well, but so if a significant time frame has elapsed post first radiation, more than a year, then there is nothing wrong in offering a re-BCS, if that is technically possible.
Okay. Dr. Jigna, so that all comes to re-irradiation and doing re-BCS in your irradiated field. What is your take on that?
If consider re-radiation within...
That will come to second. you have irradiated already. 1 year later, 13 months later, 3 by 3 centimeter breast nodule is there, lighting up on the PET, biopsy positive. Would you allow, the surgeon says that if it is okay and there is a long time passed since RT, I won't mind doing re-BCS. NCCN says कि irradiated area में BCS नहीं करने का. What is your take on that?
BCS is ultimately surgeon's opinion, but I will not irradiate in 13 months of period.
You would not irradiate. When would you irradiate again in the same area? 3 years, 5 years, 7 years?
No, after maybe 2 years I can consider.
Oh, and does it depend on the how much dose have you given? Have you given a chest wall? Have you given axilla? Does it depend on all that?
That depends on that, but in any area, if I want to re-irradiate, then the guideline clearly suggests that 2-year period is required. Considerably, if earlier, we prefer to have 4-year span, but now we are having much developed Linex, smaller MLCs, good treatment planning system, and
So
we can
2 years,
focus.
2
Yeah,
years.
so yes.
Dr. Vani.
Amish, this is going to be based on the biology, the DFI, and age of the patient, and grade of the tumor. You can't just give one answer saying, I've radiated, I will not radiate.
So
If
here,
it is a low-grade tumor,
here
it's a
is the
DCIS.
case, Vani, 46 female TNBC PT2N0, adjuvant chemo followed by RT-BCS after 4 months of completion, just 4 months of completion, 3 by 3 centimeter breast nodule, SUV 8. Now question is that BCS already पहले हुआ है, 2 by 2 centimeter में again BCS हो सकता है. Would you do it because
No.
just RT is over?
No, I'll give you an answer why no also.
Yeah.
No, because she is, one, the DFI is very short. Two, in spite of being node negative with a clear margin, she's come back with a relapse. This is not a disease where the breast has to be saved. Either there are multiple
Mastectomy.
foci which are going to come back with more disease, but she is not a candidate at all. But 1 year, if you had made it not 4 months, even then with TNBC, I would be wary about doing a reconservation. It needs to be discussed that there is still a high
So
relapse rate.
depending on the biology and the DFI and the other factors, one would decide is there. Dr. Sabu ma'am, you are nodding, so I assume that you are agreeing with Dr. Vani. Perfect. Now
Sir.
this I have highlighted PPP is for medical oncologist. Dr. Gupta, this PPP in the bottom footnote they have said that consider systemic therapy based on tumor board discussion. Now, which are the patients where you would straight away go for surgery versus systemic treatment first? See, I have just given a scenario. If BRCA is positive and PDL1 is 15%. Is a triple negative breast cancer within 9 months patient has progressed. Still local recurrence, can be salvaged with surgery.
Yes, sir.
Chemo first or surgery first?
Sir, TNBC and 2 centimeter size, I will like to give option of chemo first.
You would like to give option of chemo. Dr. Rushit?
I agree, sir. In this patient, we would like to offer chemo plus immunotherapy.
Chemo plus immunotherapy because PDL1 is 15%. Okay.
Yeah.
And triple negative. Okay. Dr. Prajapati? Chemo first?
Yes, and TNBC with BRCA positive PDL1 patient, chemo plus immuno first.
Okay. Dr. Tanay, what has failed in this particular patient? Has surgery failed? Has RT failed? Has chemo failed? What has failed?
So the most probably it is at the diagnostic level we have failed. Probably with this early recurrence in a TNBC, there must be a multifocal tumor. Patient is too young to have breast.
MRI is done, no multifocality. Let's rule that out.
So then I would like to know about the margins. If the margins are clear.
Margins were clear. All those factors are taken care of. Otherwise, we would not be discussing this case, right? Yes, Dr. Vani, patient unfortunate or we still don't know? और ये patient में mastectomy होता तो शायद patient relapse नहीं होता.
I don't think so. None of these are true because for one, this patient has, I don't have some information here, like I don't know her genetic risk. It's not there in
She
this.
is BRCA positive
She is BRCA positive.
and she has a family history. There are 7 family members दो
So breast conservation, let me start with that statement first, is safe in a BRCA positive patient.
Correct.
But
So
the monitoring and surveillance has to be
so
intense.
answer that, in a BRCA positive, BCS followed by RT versus MRM, what would you prefer in this particular patient?
If it's a small tumor feasible for, I would go ahead with breast conservation and RT.
So absolutely, that is what is done here, right? It was CT2, must be
Correct.
2.53 before. My question is here that in this particular patient, would you give chemo first or would you do surgery first?
No, in this patient, see, in triple negative breast cancer, I would like to have more information than just this. I want to know, is she node positive? Is it a small tumor? Is it a large
PET
tumor?
scan says that the recurrence is only in the
No,
breast nodule.
this is in the upfront setting, or you're showing me?
We are talking of salvage only. We are talking of
okay,
recurrence.
recurrent
only.
setting. In a recurrent
Recurrent setting 9 महीने के अंदर अंदर recurrence हुआ है, but breast parenchyma में 2 centimeter का nodule है, SUV 8 है.
See, if she has already recurred within a year's time, I would go for systemic therapy first, followed by surgery. Now that surgery may not be a salvage breast conservation again. It could be a mastectomy, but I need to discuss this with the patient. I would not opt for a conservation for
Dr.
her.
Vani, Dr. Tanay and Dr. Sagu, you need to give us a proper only 1 point answer, MRM or BCS in this patient.
Mastectomy.
Mastectomy. Clear cut mastectomy. Dr. Tanay?
Neoadjuvant chemo, immuno followed by mastectomy.
Neoadjuvant chemo, immuno followed by mastectomy. Dr. Rushit?
Sir, I would like to say that the initial treatment and the first diagnosis, if it would have been today, I would like to offer on day 1 chemo plus immuno.
Absolutely.
And followed by maybe PARP inhibitor also.
Absolutely. In the first line now we are wiser, right? We are wiser. We are offering in triple negative, although some other time immunotherapy, how much benefit in TNBC keynote 522, we'll talk about that later. Okay, if this patient surgery is first, then would anybody like to do oncotype DX in this particular patient, or straight away systemic treatment must?
No,
I'm
sir.
asking a question.
No, sir,
relapse है ना, relapse में बहुत कुछ.
It's a recurrent setting, and so we give chemo irrespective of, we don't go for that oncotype
Okay,
DSX.
particular. Fine. You know, this particular patient, I feel systemic treatment also has failed. So I am okay in 2 centimeter nodule if you do mastectomy first rather than giving the neoadjuvant chemotherapy. But here's the ctDNA definitely will work quite well if this thing is there. Okay. Dr. Prajapati, since you had the last mic, surgery done first, IHC was requested, TNBC, लेकिन बोला अब HER2 low and ultra low का जमाना है, तो turned out to be HER2 low. Would you give TDXT in this particular patient? Destiny Breast 06 included patients who relapsed within 6 months. Dr. Prajapati. You say chemo की जगह पे TDXT, तो patient says I can afford anything under the sun. Patient Viraj Lavingya का patient है.
So, sir, that in TDXD that for metastatic setting too, but in adjuvant setting will give chemo.
See, here chemo has failed, AC and T both has failed, HER2 low. So question is, will you extrapolate one trial results to a difficult scenario like this? Is a question.
Then we can extrapolate. In that
You
scenario.
can extrapolate, okay. Any of the other medical oncologists, Dr. Gupta or Dr. Rushit, will you extrapolate the data and give NHER2 to this patient? Patient is not going to sue you, I can guarantee that.
I won't offer, sir.
You won't offer. Perfect. You know, it is very difficult, as far as I am concerned, very difficult to extrapolate, because in Destiny Breast 06 it was very crystal clear, advanced unresectable metastatic disease was the criteria, so we would not do that. This patient, assuming not triple negative but HR positive at diagnosis, turns out to be HR positive at recurrence also, and on adjuvant hormone in less than 1 year after surgery, patient progressed. What would you do? Would you do oncotype DX here? Dr. Rushit, you have given chemotherapy के और hormone के भी, इससे primary hormone refractory, primary looks like chemo refractory also. Would you do oncotype DX here, or you say no, I will move forward and give CDK4/6 with fulvestrant or anything like that? Or would you still give standard chemotherapy?
So in this case, I would not do Oncotype DX first of all.
You would
and
not do.
Yes, and I would like to give chemotherapy followed by, after surgery as a.
Assuming this patient would have relapsed after 3 years, would you do Oncotype DX? Secondary hormone पे आ गया, primary से.
Recurrent cases, I am not doing, sir, Oncotype DX.
Agreed, but so assuming if we do Oncotype DX and the score comes 8 after 3 years of progression, would you offer chemotherapy in that patient?
I would still like to offer, sir.
You would still like
I am
to
not
offer.
comfortable.
Fair choice, there is no clear-cut guidelines here. Dr. Gupta, would you do Oncotype DX? I found there are 5 case reports, what they discuss in the seminars of oncology. I took 5 cases from there. 4 out of 5 in a case like this, they have done Oncotype DX, and 2 patients, the score was low, they didn't offer. And at 5 years, they found that patient has not relapsed. That's why I raised this point.
Sir, commonly I don't do Oncotype DX on recurrent setting.
Commonly, you don't do Oncotype DX. Dr. Prajapati?
Sir, in that case, can we know the Oncotype DX on the first specimen? What was this?
Would you like to do on the first also? I am asking,
No,
first
upfront.
Oncotype DX is not done.
Yes, it was, if it is T2N0 and at upfront it is hormone positive, HER2 negative, which has recurred in 3 years. So what was the?
No, Oncotype DX was not done at that time.
Okay.
See, imagine patient is mine. I am not a big fan of Oncotype DX. I see many other factors and decide for 4DC. But Oncotype DX was not done. Now, would you do Oncotype DX? Save the patient from chemotherapy? Second time? No.
No.
We are medical oncologists. How can we say no to chemo? Dr. Vani, do you think this question makes any sense? Because seminars of oncology I took, I would not have thought of doing Oncotype DX.
Let's be very clear, there's no evidence of
There is
using
no evidence, and that's
Oncotype
why we are
DX in a
discussing.
recurrent setting, and that too when, so the criteria that you always stick with is going to be the clinical criteria. What was the DFI, and where is the
So
site of
DFI
recurrence?
say 3 years.
And where is the site of recurrence and extent of recurrence? I think that still controls
No,
and dictates our
local recurrence and DFI is 3 years. HR positive begin with HR
So
positive
she has
now.
primarily responded for a while, but now become resistant.
Secondary
So we are going to
resistance.
look at CDK4/6 along with the second line hormone therapy.
And in a R0 resection of recurrent chest wall disease, where is the evidence of CDK4/6 inhibitor? We don't
Well,
have.
there
We
is-
don't have.
That
right?
also we don't have.
So,
it will be a
there is
second
no
line
evidence
treatment.
anywhere. I feel it made sense. When I read this, I felt it was making sense. If you have Oncotype DX high score, you know that you can freely offer chemotherapy, but each panelist to their own. Let's talk of this, and Dr. Jigna. The same patient had 3 bony lesions after 1 year of treatment completion. We are going back to triple negative stroke HER2 low, not HR positive. Okay. So the questions are, in bone only, if the patient comes to you in a tumor board, said कि भाई oligometastasis है, Dr. Jigna आप RT दे दो. Let's look at curative zone. Would you like to do a bone biopsy to confirm that it is METs? SUV is say very high.
No, I within 1 year, I mean it is only 1 year of the treatment and recurrence time. So an SUV is high, then I would not prefer to go for biopsy.
Not prefer. Any of the panelists would prefer to go for biopsy here. Bone biopsy, difficult. Spine का bone biopsy GA में करना पड़ता है. टाक 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 टोक के करते हैं.
Whenever possible,
Whenever. Would you do in this patient?
I
or
would
not?
do.
You would do. Any of the panelists, Tanay Sahib, would you do biopsy? I know you are going to refer to RT or medical onco here.
But still I would prefer to do a bone biopsy just to make sure that the biology is
I'll
the
take
same.
2-3 minutes more.
Yeah, I would
You would
prefer.
like to do. Dr. Prajapati.
Definitely this is recurrence, but for biopsy we will get to know that what is the receptor status further.
What is the receptor status? Okay, perfect. So, Dr. Jigna, 4:1. All other 4 panelists have said they'll do biopsy. Before radiating now, would you do biopsy in this patient?
I am okay with that if patient is ready.
Okay. I give this example to everyone. This happened with me 1 year back. Okay. And I have started doing biopsies more frequently in last 2-3 years. There was one pancreatic patient, surgery done, Whipple surgery done. I had given chemotherapy. After 6 months, there was a peritoneal thickening, ascites. ascites set some atypical cells, peritoneal thickening, wide. I did a Zoom call with patient for 45 minutes and I said 3 to 6 months, don't do anything. I said, ek karana hai to peritoneal biopsy kara lo. It came out to be florid disseminated tuberculosis, and I fell flat on my face telling 5 family members that कि अब 6 महीने से ज़्यादा नहीं है. It is almost 1 year and this patient is absolutely fine right now on ATT. So I think I learned my lesson. Wherever possible, I think we should do that. Okay. Dr. Jigna, 3 lymph nodes, 3 bony, we are short of time. Very quickly, 3 bony mets. Would you like to give systemic treatment first, or you can easily radiable?
Yeah, I will go for palliative RT to that bony lesion first, because it will take shorter time, and then
it will
for
take
the
a
systemic.
shorter time. Dr. Jigna, you are radiated on this patient. See, it's a triple negative high grade breast cancer. You are radiating, and during radiation one more new bony lesion pops up. What are you going to do with that?
During irradiation of the local area, patient
you
is
are you are radiating 3 sites, okay, and during radiation patient says pain hua, and you do interval scanning, उसमें एक और bony lesion pop up होता है.
If patient is symptomatic, other biopsies are positive, then yeah, along with that, if I can
You'll radiate
irradiate
that
it,
also. Okay.
if it is possible.
Medical
yes.
oncologist, you believe systemic first in an oligometastatic early relapse. Should we give systemic first, salvage and control the disease and then give RT? Dr. Prajapati.
So depend on the patient. If patient is in severe pain, will give RT first, palliative. Otherwise, patient not symptomatic and is well, then will give systemic therapy.
Then
Systemic treatment.
systemic treatment first. Okay. Dr. Gupta, systemic first or RT first? And the second last question, because we are running short. If this patient is HR positive and patient was on adjuvant letrozole, and you have a 1 bony lesion, Dr. Jigna has radiated, would you continue letrozole or would you add CDK4/6 inhibitor?
So, sir,
Single bony lesion.
Yeah. So first question, I would like to prefer systemic therapy first.
Systemic therapy
If
first.
patient is not in much pain.
If patient is not progressing in 6 months, then you radiate. I
Yeah.
follow the
And
same.
for the second question, sir, I would like to add a CDK4/6 inhibitor, and if possible, I will also like to change from letrozole to the fulvestrant.
Fulvestrant plus ribociclib, probably. That is, I think, what all the medical oncologists would do. Here we have a metastatic disease which is there. Quickly, any of the medical oncologists will do NGS at all recurrence or only in metastatic recurrence? Dr. Rushit can take that.
Not the very detailed NGS I am doing currently. Not doing.
This particular patient with 3 bony lesions turns out to be BRCA positive. Would you add olaparib in adjuvant setting after radiation?
Yes, sir. I would like to add.
You would add olaparib. If the patient is PIK3CA positive, Dr. Gupta, would you change to alpelisib plus fulvestrant?
Yes, sir.
You would change.
Yes, sir.
And all these, after we have our intent of treating oligomet is curative. Okay. HR positive, you have already told about that. This is something which I had kept, but I would not go into detail. Only thing which I wanted to ask, and let me start. Dr. Tanay, patient is your follower. No matter wherever medical oncologist goes, you know, they come back to you and say कि sir, Dr. Vora ने किया है, हमको ठीक नहीं लगता है, आप क्या बोलते हो? How many times in your practice do you ask patient, not the relatives, आपकी क्या इच्छा है? Do you want to be treated, or what is your goal of the treatment? Because you know, we are trying to salvage the patient and not just the disease.
For a 43-year-old lady, I would rather refrain from asking that question कि आपकी क्या इच्छा है. I'll also explain the treatment options.
Liver disease, bony disease, brain met, you know, everything is there. Would you ever ask, say, assuming 60-year-old patient?
Yeah.
In India, only families decide, the relatives decide.
I'll give the options to the patient that apart from the longevity, it is the quality of life which he is going to live with for whatever remaining years are there. So there has to be something on offer to the patient with minimum toxicity, if that can be offered by medical oncology colleague.
Right. Dr. Rushit, how many times in a patient receives 6 different lines of chemotherapy? Dr. Vani is bored of us, कि भाई, you know, why are they not letting this patient go? How many times do you actually counsel? At every recurrence, do you counsel the patient and do you document? Or once in a month, once in 3 months?
No, we document and discuss at each progress, each relapse. Each relapse may not be at the first visit with the patient, but in subsequent visit we do discuss with the patient also, apart from relatives.
Okay. I find it in my practice, find it very difficult to talk to patient directly, because majority of the times the relatives, they say कि sir mat batana, ye mat karna करके. But I feel we need to change our practice, and we need to tell the patient directly that what is your wish. I have started writing now death in my file, which I was reluctant to write, that I have explained to patient that patient is going to die very soon because of this karke. Because the lawyer demands that if you have not written the word death, in future patient say कि मुझे तो पता ही नहीं था कि this is what is going to happen. Last question to Vani, and we close this panel. Vani, this particular patient, 43-year-old female, bone, liver, lung metastasis, wants to go for adoption of a child. This has happened with me, true story hai. She said, I can't conceive, but I want one child to be adopted. I said, आपके जाने के बाद क्या होगा? बोलते मेरी family संभाल लेगी. What would you tell the patient?
I think to be fair to the child, I would say no to her.
You would say no to them. Okay, perfect. Fair enough. Any of the panelists disagrees with Dr. Vani, or everybody would say the same?
Agree.
Agreed. Okay. Thank you so much all the panelists for good discussion, and thanks the organizer.